Hey team, this is Alison Moe from Atlanta Gastroenterology Associates. Thanks for joining me for the GAP MASLD MASH Community Network. Today we're going to be talking about a case study and we'll be talking about some diet and lifestyle management and how we do some education on metabolic associated steatotic liver disease. You can use this QR code to go ahead and get yourself scanned so you can record your attendance for the meeting. We're going to start with a clinical case study. This patient is a 65-year-old male named Albert. He has past medical history of obesity. He also is Hispanic and a BMI of 29. And he was referred to you in the clinic for elevated liver tests and for some abnormal imaging with an ultrasound that showed increased echogenicity, which was consistent with fatty liver. On his labs, just as a review from his referring team, he was noted to have triglycerides of 89. His HDL and hemoglobin A1C were not terribly bad, but his ALT was the upper limit of normal for several years at 1 to 2 times the upper limit of normal. All of his other etiologies for chronic liver disease per this scenario are negative. So in the clinical setting, we would, of course, do a secondary liver workup to look for other reasons why a patient like this has elevated liver tests, even though we would be pretty sure that it was secondary to fatty liver given his hemoglobin A1C and his underlying metabolic factors. He has not drank any alcohol since his 20s. He does, as I mentioned, have high cholesterol, hypertension, type 2 diabetes. And on exam, the things that we look for to make sure patients don't have any significant advanced liver disease are negative. So he has his weight in his belly, but he does not have any telangiectasias. He doesn't have any lower extremity edema. He's not jaundiced, etc. So based on this, he has imaging that shows he's consistent with fatty liver disease. And because we know he's not a drinker and his secondary liver workup is negative, we're going to say that this gentleman has metabolic associated steatotic liver disease. So on our MASLD care pathway for patients like this, when I see them in the office, we have to determine which patient probably just needs a little bit of a follow-up in the future versus a patient that needs a little bit more of risk stratification of their disease. So his ALT and AST, are not terribly higher than normal, but his platelets are lower than what I would say for a normal range platelets. Generally less than 140,000 we would say is consistent most likely with advanced cirrhosis. But his FIB4, which is a calculation that we look at to check for age and platelets and AST and advanced risk of liver disease, is elevated at 2.2. And anybody who's more than 1.3, we say definitely has some possible elevated risk. And anybody that has a FIB4 greater than 2.67, we are pretty confidently sure likely has some advanced fibrosis. So based on our risk stratification diagram here, if we have a patient who has 2 or more risk factors, so including things like diabetes, hypertension, hyperlipidemia, polycystic ovarian syndrome, type 2 diabetes, that patient gets a CBC liver function tests, and we screen obviously for alcohol. If their FIB4 score is somewhere within the range that I just mentioned, that may determine whether or not the patient is not an elevated risk and they don't have a risk of advanced fibrosis. So we just repeat their non-invasive testing in 2 to 3 years unless the hemoglobin A1C becomes significantly dysfunctional and their diabetes is poorly controlled. Do they gain 50 pounds, etc.? Then the intermediate risk of patients, where I would say is where most patients fall into, are the people who have this multiple comorbidities, including the hypertension, hyperlipidemia, obesity, etc. Their FIB4 falls somewhere within that 1.3 to 2.67 range. And then when we do our liver stiffness evaluation with our FibroScan or elastography or MRI, PDFF, whichever is your available diagnostic measure, that's where most of our patients fall, is inside that moderate risk. And then our high risk patients obviously are people who probably have very low platelets, elevated FIB4 greater than 2.67, and on their liver stiffness evaluation, it's really high, their KPA is greater than 12. Based on this risk stratification, I would say that our patient, because his KPA on his FibroScan is a 6.7, that says that he's low risk based on our kilopascal score on the FibroScan. So for him, his FIB4 was 2.2, so that puts him in the intermediate risk, but then his KPA is 6.7. So that person would get lifestyle modification, meaning lose weight, get the BMI down, get that hemoglobin A1C as close to less than 7 or even 6 as possible, and then following up on his non-invasive testing. We now know that people who have metabolic associated fatty liver disease are the highest risk category of patients to advance to fibrosis. If a patient is overweight, has type 2 diabetes, or has any of the metabolic dysregulations that we just mentioned, that patient is at an increased risk of going from steatosis to steatohepatitis to then fibrosis, which we now know are all reversible. We can go from fibrosis all the way back to a normal, healthy liver, but we do not yet have any medical therapy or indicative therapy that once a patient has cirrhosis, that we have any options for reversing cirrhosis. What are the risk factors for patients having advanced fibrosis or being at risk for having metabolic associated fatty liver disease? Some of these are very easy. We know that there are patients who, based on their ethnicity, are at increased risk because of diet and cultural changes. There are people who eat a lot of fats and sugars and sodas, who have saturated fats versus unsaturated fats. All of these things affect the lipogenesis of fats in the liver and ultimately can lead to patients having more advanced fibrosis. The reason why this has become such a discussion recently is because obviously we have an obesity problem in the United States and all over the world. We have more children who are diabetic than we've ever had before, and a lot of it has to do with the poor diet choices that people are having, but it's convenient. You know, we talk all the time about this elephant in the room, is that you don't want to have to say to a patient, well, the reason why you have what you have is because of your obesity. But unfortunately, that has to be a conversation that's had, because we have to address the patient's weight in order to be able to address all of the other things that come along with being obese, including your diabetic control, your lipidemia control, etc. When I manage my patients who have obesity as well as metabolic associated steatotic liver disease, I do talk with them, especially if they are centrally obese, about insulin resistance and how we deal with these non-inflammatory diets. It's not just about not having social alcohol. It's not just about losing weight. It's about being able to educate patients on the choices of the things that they're eating so that they have the best chance at succeeding. So let's go back to Albert. In his situation, we say to him, you know, what is it that you are mostly eating? Because we want to talk about his diabetic control. And we want to talk to him about his glycemic index, and we want to talk to him about his central obesity. He says that he's Cuban and he eats a lot of rice and beans and pork and corn and beef and plantains. This is not the food type that's considered a Mediterranean diet, which is what our recommendation is for patients who normally have metabolic associated steatotic liver disease. So I want to always be careful, because patients who have long-standing cultural diets and cuisine is something that we don't want to be ignorant to, but at the same time, we have to talk to our patients to make sure that they have access based on their socioeconomic status, as well as education as to what the correct food choices are for a patient who has underlying diabetes and who has metabolic associated liver disease. So, for example, with Albert, I would say to him, why don't you not eat these heavy starch-rich foods Monday through Friday and leave those to the weekend foods? And let's talk about uh, um, the appropriate foods for you to be eating for your underlying fatty liver disease and your diabetes on a more regular basis. It's hard. It's hard to talk to patients about dietary and lifestyle changes. Everybody kind of wants a pill for something and everybody wants to have a medication for something. However, we know that if we have a patient who improves their glycemic index and patients who improve their BMI, it is an absolute correlation with a histologic outcome of improving their steatotic liver disease. Before we had drugs available to help with fibrotic liver disease, if we had our patients lose 10% of their body weight, we would tell them that within 6 months they may see a change on imaging, including a resolution of fatty liver. We know that being sedentary, sitting behind a desk, not doing aerobic and resistance exercises, we know that this Western lifestyle, those are things that are all risk factors to leading us towards the metabolic associated dysfunction. We know things like aerobic exercise and resistance training and a Mediterranean diet are the things that help us move towards a healthy liver and an overall better lifestyle measures. Resistance training, which usually requires less energy and leads to less fatigue, which patients usually want to push back at when it comes to exercise, especially if they're morbidly obese. Those are the things that do not need to have significant shortness of breath and cardiovascular endurance in order to be able to do. So rather than patients doing jogging or running, etc., let them do resistance training where they're using weight bands or even cans of food, something to be able to help them with overall muscle workouts, but do not need to be aerobic exercise. I find that when I'm talking to patients about the Mediterranean diet, it also helps to talk to them about things like intermittent fasting. It's not necessarily a massive calorie restriction, but because they're not eating consistently throughout the day, it does a good enough job to help with ketogenesis. And it also helps with things like bloating and fatigue because of fat starvation and starch starvation to our cells. Hands down, the Mediterranean diet is the way that we go. It's talking about good fats, picking things like salmon instead of excessive red meat, picking things like vegetables instead of French fries. And it's really what's recommended by the AASLD, AACE, and European guidelines recommended for primary lifestyle intervention. Interestingly, the European guidelines also recommend drip coffee as something that may improve fatty liver disease. And I always specify that with my patients. They do not mean the Starbucks drinks with all of the foams and sugar additives. So based on all of this, we have Albert, who returns for follow-up with no improvement in his labs, despite the fact that he is admitting to helping with a better diet and lifestyle. He has not done any exercise, but he's been trying to cut out soda. So what do I say to Albert when we've gone over all of the things that are necessary for him in order for him to improve his overall health and not prevent him from getting any further fibrosis of his liver? And I do very clearly give patients short-term interval goals. So I'll say things like, in the next 8 weeks, when you come to see me, you have to lose 5 pounds. I don't give unrealistic expectations like you need to lose 50 pounds, otherwise your liver disease is going to continue to progress. So if we give short little interval goals, that's usually much more well responded to by patients, and they can do much better and they can adhere to all of those goals. The EDA, which is a exercise and diet adherence scale, is something that has really good questionnaire for how patients can monitor their exercise and their caloric intake. Uh, Use this QR code to visit the GAP MASLD MASH Community Network to view all of the information we talked about here, as well as the disease state education and Resdifra promotional program, which of course is what we're going to talk about in regards to what we would do next for our patient like Albert, who was not responding to diet and lifestyle modifications as well as we would have liked him to. If anybody has any questions, I'm happy to help with whatever I need to. Otherwise, thank you guys so much for your time. I look forward to seeing you again and look forward to all of our connections through the MASLD Community Network. Have a great afternoon.